you will have persistent systolic blood pressure more than 130 mmHg, or diastolic blood pressure is more than 80. So remember, this question is also high yield. Okay, first step one and two. Okay, a patient comes to you. Okay, you have checked the blood pressure in one setting. You will not diagnose it as a blood pressure. Okay, okay, remember this. Okay, in just patient have come, you have checked high blood pressure. It doesn't mean it is hypertension. Okay, so so next, if there is two ways to confirm the actually blood pressure, you will check in three settings. Either if you ask the patient to come in the hospital at three different times, okay, you can check that hypertension. Either other way, according to your word, okay, so there is called, you will check continuous blood pressure monitoring, okay, for 24 to 84 hours. Okay, you will check the blood pressure of that patient continuously. Like you check the ECG, that is called telemonitoring, like that. Okay, here you will check continuous blood pressure for 24 to 84 hours. If blood pressure is constantly raised, that is hypertension. Or, or another point, you will ask the patient to check blood pressure twice a day for 1 week. You will ask the patient to check blood pressure twice a day, morning, evening, and for a week, and write down those blood pressure. So there are three ways. Three office setting. Okay. Two is the in home setting. Okay, there are two ways. In home setting, either for 24 to 84 hours, check blood pressure continuously, or check blood pressure by yourself, okay, twice a day for 1 week. Okay, then you can diagnose it a hypertension. Okay, remember, this is a way. If patient have hypertension plus its complication, patient come with hypertensive complication, okay, you will go toward the antihypertensive medication. Like patient comes with, like, have hypertension and stroke, patient come with retinal hemorrhage, patient come with aortic dissection. Okay, then you will not, okay, wait for to confirm blood pressure in three setting, check blood pressure at home, like that. Okay, just give the bloody antihypertensive to that patient. Patient asymptomatic, no end organ damage, first time hypertension, go toward confirm the diagnosis. But if patient have hypertension plus mean blood pressure more than 130 or 80, plus you are having any type of end organ damage, go toward antihypertensive. This is very important MCQs. Okay. Then risk factors, some of them is modifiable, other are non-modifiable. Okay, increased age, obesity, diabetes. Okay, so diabetes is the worst risk factor for hypertension. This question can become, which one of them is the worst risk factor? That is the diabetes. Physical inactivity, high sodium diet, excessive alcohol intake, tobacco smoking. Okay, which one of the, actually, next question is like that, which one of risk factor, if you prevent that risk factor, okay, okay, mean if you prevent the risk factor, okay, you will have suddenly decrease in hypertension. So that is the smoking. And you stop smoking within 2 or 3 years, okay, 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 you will have changes in even hypertension. Also, when you stop smoking, you will have decreased progression of COPD. Smoking is the one of risk factor. By stopping that, okay, prognosis will be good in less time. Then family history, in incidence increase in black, white, and Asian population. Okay, remember this. Okay, so consecutive 3 readings are required to diagnose the blood pressure. And which one of them the cause of death in hypertension? That is the MI. And what is the drug of choice in hypertension? Okay, that is the diuretic, like the thiazide diuretic. Okay, remember this. Then features, okay, 90% are the hypertension is essential, it is idiopathic, not due to any other cause. Like it can be due to increased cardiac output or increased TPR. Remaining 10% is due to 10% is due to renal vascular disease such as fibromuscular dysplasia, or also atherosclerotic renal artery stenosis are due to primary hyperaldosteronism. Guys, there are multiple causes, almost 10, more than 10. Okay, you have to cram all of them. Okay, I will go. Okay, here I will just two or three important points. I will share the flashcard with you. Okay, so remember, if young female history is given, okay, and you are having hypertension, that is fibromuscular dysplasia. Okay, here you will have a string of bead appearance of renal artery. Here it is given. Okay, it is common in adult female, young adult female. Like history will be 20 to 30 years. Okay, this history will be given, and you will have resistant hypertension. Okay, so that is for fibromuscular dysplasia. For atherosclerotic renal artery, we have discussed before. Okay, in the renal section, history will be given of elders. Also, there is a primary hyperaldosteronism. So now I will discuss some of them causes. Secondary hypertension can be due to chronic kidney disease. In chronic kidney disease, it's no doubt creatinine will be elevated. Second cause is obstructive sleep apnea. History will be given of daytime somnolence, snoring history. Okay, so these type history will be given. Also, obesity is a major risk factor in obstructive sleep apnea. Chronic NSAID use, OCP use, okay, like the OCP, combined oral contraceptive, pseudoephedrine use. If you are using, okay, pseudoephedrine for like you do rhinitis, okay, you can add 12 secondary hypertension. Then drug, cyclosporine and tacrolimus. These questions have been asked in you. Cyclosporine and tacrolimus. Okay, they cause renal vasoconstriction. Then is primary aldosteronism, either either adenoma, either bilateral idiopathic or renal hyperplasia. In both cases, you can develop, you will have more aldosterone. When you have more aldosterone, you will have absorbed more sodium. Okay, here you will have hypokalemia, you will have metabolic alkalosis, and you will have resistant hypertension. That is primary aldosteronism. Then in Liddle syndrome, we have discussed that, okay, you will have increased the ENaC, epithelial sodium channel. Then pheochromocytoma. Here you will have episodic fluctuating release of catecholamine. So you will have episodic sweating, palpitation, headache, like that. Then Cushing syndrome. In Cushing syndrome, okay, guys, okay, you will have uh, more cortisol, okay, you will have hypertension. What is the reason here? Actually, cortisol increase the sensitivity of vessel toward catecholamine. Then renal artery stenosis, we have discussed that. Fibromuscular dysplasia, we have discussed that. Correction of aorta is also secondary hypertension cause. Then is the autosomal dominant polycystic kidney disease. Okay, you will also have secondary hypertension in that. Okay, see all these secondary causes. Guys, remember, examiner love is which one of the cause is the examiner main focus. It is the renal artery renovascular disease. Guys, remember, elder history, that is renal artery stenosis. Young female fibromuscular dysplasia. Okay, done. Third common cause is primary aldosteronism. Okay, so these three, and fourth one is the Cushing syndrome. These four causes are common one. Okay, remember. Then is hypertensive urgency. If blood pressure is more than 180, 120 without acute end organ damage. Then is hypertensive emergency called malignant hypertension. When you have severe hypertension with evidence of acute end organ damage like encephalopathy, stroke, retinal hemorrhages, okay, exudate, papilledema, MI, heart failure, aortic dissection, kidney injury, anemias, and eclampsia. Here in arterioles, you will have fibrinoid necrosis. Also, you will have hyperplastic arteriolosclerosis. We will discuss in the next page. In malignant hypertension, you will have so in malignant hypertension there are three important points. First, fibrinoid necrosis, and guys remember fibrinoid necrosis is present only in other one vasculitis, that is the polyarteritis nodosa. In that you will also have fibrinoid necrosis of vessel. Second point, important point, you will have hyperplastic arteriolosclerosis. Third point, on kidney, you will have flea beaten appearance. In kidney, you will have flea beaten appearance. That is for malignant hypertension. It predisposed to coronary artery disease, most common cause. Left ventricular hypertrophy, heart failure, atrial fibrillation, aortic dissection, stroke, aneurysm, CKD, retinopathy. So that's it. Which one of them is the most common cause of death in hypertension is the MI. It is my. Okay. Best initial therapy is with lifestyle management. Okay. So if first time patient is diagnosed in hypertension, you will ask them weight loss. Weight loss is a more effective way. Okay. Also is the diet, exercise, tobacco cessation. So guys, okay, so I will share with you a flashcard of antihypertensive. Okay, if you are doing weight loss, dieting, exercising, tobacco cessation, which one of them is most effective? So it is the weight loss, because when you decrease the okay, when you decrease the, I think, you know, 10 kg weight loss, okay, when you decrease 10 kg weight loss, okay, 6 mmHg will be decreased. The blood pressure decreased by 6 point. Okay, so the most common cause of death in hypertension, okay, that is the MI. Okay, so causes of secondary hypertension, I'm again repeating, it can be no, I am taking from the organs. So this flashcard is from Goljan pathology. Like a renal. In a renal, it can be Cushing syndrome, it can be pheochromocytoma, it can be neuroblastoma, it can be lemon hydroxylase deficiency, it can be primary aldosteronism. Then for aorta, it can be fractation, it can be also common in elders. Okay, in elder it is called isolated systolic hypertension. Then in CNS, you can have intracranial hypertension. Then drug, it is oral contraceptive, cocaine. Then parathyroid, it is primary hyperparathyroidism. Then in pregnancy, it is the preeclampsia. Then renal, there are two diseases. Renovascular disease, like in elder, it is atherosclerosis. In women, it is the fibromuscular dysplasia. Also is the renal parenchymal disease, like diabetic nephropathy, ED, PKD, okay, glomerulonephritis. Then in thyroid, it is a grave disease. Also, you will have, guys, remember, in hypothyroidism, you will have hypertension. In hyperthyroidism, you will have hypertension. But here is the important point. In hyperthyroidism, you will have systolic hypertension from increased cardiac contraction. In hyperthyroidism, you will have systolic hypertension. But in hypothyroidism, it will be diastolic hypertension from due to retention of sodium. Okay, so in hyper it is systolic hypertension. In hypo it is diastolic hypertension. Okay, so I will share that flashcard. Okay, next we will go toward hyperlipidemic sign. Actually, hypertension is so vast, so high yield. Okay, we can actually do one day lecture upon hypertension. So I'm just sorry to you. I'm just going forward. Okay. Okay. If you have any question regarding hypertension, you can ask me. Then is a hyperlipidemia sign. One is xanthomas. It is given in the eyelid. Here you can see it is given in the eyelid. It is also present on the skin. Here it is common in the hyper. It is common in the hyperchylomicronemia. Increased lipid level. You will have these xanthomas. Tendinous xanthoma, lipid deposit in the tendon. Here you can see it is given, especially Achilles tendon and the finger extensor. Then is the actually next is the corneal arcus. It's like that lipid deposit in the cornea. It is given. It is common in older adult, that is arcus senilis, but appear early in life with hypercholesterolemia. So guys, please focus on the copper ring, that is a Kaiser Fleischer ring, that is given also in cornea. Okay, see the difference between the their ring present in copper. Here is the given in the corneal arcus. Okay, then is arteriosclerosis, hardening of arteries with arterial walls thickening and loss of the elasticity. So other is one of them is a arteriosclerosis. Okay, so most of the time students confuse arteriolo and atherosclerosis. Athero, athero is for large and medium sized artery, large artery. Here you will have atherosclerosis. Okay, it is for large size artery. Arteriolo is for arterioles. Arteriolo is for arterioles. Affect which arteries? Small arteries and arterioles. So there are two types, haline and hyperplastic. Okay, in haline arteriosclerosis, you will have thickening of vessel wall secondary to some protein. That's why it's called haline. Haline is also called protein. Okay, plasma protein leak into endothelium in essential hypertension or diabetes mellitus. Okay, third one is the aging, that is given in pathoma. Essential hypertension, diabetes mellitus, and aging. In aging, okay. Here you can see, guys, this is very important histology. Here you can see this is the endothelium and this is a lumen. Between the lumen, you are having this pinkish material is present. That is a protein. Okay. Then hyperplastic, it is that is called onion skinning. Here you can see onion skin. It will be like that. It is present in malignant hypertension with proliferation of smooth muscle cells. Okay, so hyperplastic arteriosclerosis, fibrinoid necrosis, and flea-bitten appearance of kidney, that are signs for malignant hypertension. I will repeat: hyperplastic arteriosclerosis, fibrinoid necrosis, and third is flea-bitten appearance of kidney, that is for arteriolosclerosis. Then is Monckeberg sclerosis. It is also called medial calcific sclerosis. It is uncommon. Okay, it affects the medium-sized artery. Calcification will be on the media. Okay, you will have vascular stiffening without obstruction. Remember, no obstruction. It is called pipe stem appearance on X-ray. Here you can see that does not obstruct blood flow. Edema is not involved. Okay, that's it. Next are a very important topic, atherosclerosis. We will discuss that.